Hello, everyone. My name
Okay.
is Amil Družić, and I am happy to be here with you all at the Global Cancer Movement, challenging the status quo in colorectal cancer. I am an oncology and radiotherapy resident at the Oncology Clinical Center, University of Sarajevo, and I also serve as the sub-investigator for the International Watch and Wait database registry for my site. And today we will talk about the organ preservation in locally advanced rectal cancer. We will also speak about the organ preservation early rectal cancer, unlocking the potential of the watch and wait approach. We will start by a brief historical context of the rectal cancer management through the years. So let's explore the journey of rectal cancer management, showcasing milestones that shape today's patient-centered and organ-preserving approaches. In 1908, William Ernest Miles introduced abdominoperineal resection, a surgical breakthrough, but one that left patients with permanent colostomies and reduced the quality of life. In the 1940s, Dixon's anterior resection preserved the sphincter in upper and middle rectal tumors. Later, in the 1970s and 1980s, we saw the low anterior resection and total mesorectal excision, pioneered by Dr. Bill Held. TME became the gold standard, drastically reducing local recurrence rates. From 1990s to 2000s, multi-modality treatments emerged. Trials like the Swedish rectal cancer trial, the German rectal cancer trial showed preoperative chemoradiotherapy reduced local recurrence, preserved sphincter function, and achieved pathological complete responses in 15 to 20% of the patients. In 2004, Dr. Angelita Haber-Gamma introduced the watch and wait approach. Patients achieving clinical complete response after chemoradiotherapy could safely avoid surgery, improvising quality of life and advancing organ preservation in selected patients. In 2010, total neoadjuvant therapy was introduced to address micrometastatic disease earlier. Trials like the Polish 2 trial, Rapido trial, Prodigy trial, the CAO-ARO-AO trial established that TNT is the standard for locally advanced rectal cancer, improving complete clinical response, pathological complete response rates, and enabling organ preservation in selected patients. From 2020 to 2024, the OPRA trial integrated the TNT with watch and wait, consolidation chemotherapy, improved organ preservation rates in 53% compared to the induction arm at 41%. The OPRA update in 2024 confirmed its safety and efficiency, cementing this approach in modern rectal cancer management. So we are continuing to the next slide. What is the watch and wait approach in rectal cancer? The watch and wait approach in rectal cancer is an innovative, non-operative management strategy for patients with rectal cancer who achieve a clinical complete response after neoadjuvant therapy. Unlike traditional surgical management, this approach prioritizes organ preservation and quality of life by avoiding surgery in patients where no residual tumor is detected. The strategy was pioneered by Dr. Angelita Haber-Gamma in 2004, and since then it has gained significant traction worldwide. It involves close and regular monitoring through digital rectal examination, endoscopy, and advanced imaging techniques like MRI. This meticulous surveillance ensures any tumor regrowth is detected and treated promptly. One of the key advantages of the watch and wait approach is that it allows patients to avoid the risks and complications of surgery, such as permanent colostomies or impaired bowel and sexual functions, without compromising oncological outcomes. However, this approach demands strict adherence to follow-up protocols, making it essential that patients are well informed and highly compliant. So which patients are suitable for watch and wait? Not all, of course. Not all patients are candidates for watch and wait approach. The decision to opt for this strategy is based on a rigorous selection process to ensure safety and efficiency. The ideal candidates are patients with locally advanced rectal cancer who have undergone neoadjuvant therapy, a clinical complete response, which is confirmed through a combination of digital rectal examination, endoscopy, and a high resolution MRI, no evidence of distant metastasis or extramesorectal diseases, strong commitment to follow-up care and adherence to a strict surveillance protocol. This approach is particularly beneficial for low rectal tumors, where preserving the rectum can have a significant impact on the patient's quality of life. However, patients must understand the importance of intensive monitoring as tumor regrowth is possibility, especially within the first 2 years. Ultimately, the watch and wait approach is a shared decision-making process between the patients and the multidisciplinary care team, balancing oncological safety with the patient's desire for organ preservation. So what is a complete clinical response? The complete clinical response is the cornerstone of organ-preserving strategies for rectal cancer. It is defined as the absence of detectable cancer following neoadjuvant therapy. This assessment relies on 3 main tools: digital rectal examination, endoscopy, and high-resolution MRI. The concept of a complete clinical response was introduced by Dr. Angelita Haber-Gamma in 2004, who demonstrated that patients achieving complete clinical response could safely avoid surgery and pursue non-operative management strategies. The key features of a complete clinical response include a normal mucosal appearance on endoscopy and absence of residual tumor signals in MRI. The significance of achieving a complete clinical response cannot be overstated. It serves as the foundation for the watch and wait strategy, allowing selected patients to preserve their rectum and maintain quality of life. However, identifying a complete clinical response requires advanced imaging techniques and multidisciplinary team to ensure accurate evaluation and prevent overtreatment or undertreatment. Dr. Angelita Haber-Gamma's landmark 2004 study, published in the Annals of Surgery, fundamentally changed the way we approach rectal cancer management. This study, titled Operative versus Non-Operative Treatment for Stage 0 Distal Rectal Cancer Following Chemoradiation Therapy, demonstrated that patients with Stage 0 rectal cancer who achieved a clinical complete response after neoadjuvant chemoradiation could be safely managed without surgery. The long-term results show no significant difference in survival between those two who underwent surgery and those who were managed by non-operative way. More importantly, the study highlighted that non-operative management spared patients from the morbidity associated with rectal surgery, including sexual, urinary, and bowel dysfunction. This finding paved the way for the development of the watch and wait approach, significantly improving the quality of life for many patients. The study is considered one of the most influential works in rectal cancer management, being the only Latin American contribution included in the 100 most cited works in surgery by the World Journal of Surgery in 2018. It reflects the importance of innovation in challenging traditional paradigms and prioritizing patient-centered care. So let's see what are the MRI characteristics of a complete clinical response. MRI plays a critical role in assessing a complete clinical response by providing detailed visualization of the tumor bed after neoadjuvant therapy. A complete radiologic response in MRI is characterized by the absence of residual tumor signals. The rectal wall either appears normalized or shows a thin, linear, or crescendic scar. Key radiologic features include low T2 signal intensity, which indicates fibrosis, and no diffusion restriction on the diffusion-weighted imaging, confirming the absence of viable tumor cells. These findings are critical for distinguishing true clinical complete response from post-treatment changes such as fibrosis or scarring. High-resolution pelvic MRI combined with functional sequences like diffusion-weighted imaging ensures precise assessment and helps determine whether a patient is a candidate for organ-preserving strategies or not. So we are continuing now to the endoscopic characteristic of a complete clinical response. Endoscopy is a vital tool in assessing complete clinical response, as it provides a direct visual evaluation of the rectal mucosa. The hallmark of the complete clinical response on endoscopy is a flat white scar at the tumor site, indicating successful mucosal healing without residual disease. Additional features include the absence of ulceration or nodullarity, which might suggest rectal tumor. In some cases, telangiectasia may be observed, reflecting the effects of radiotherapy and the healing process. Endoscopic findings, when combined with MRI and digital rectal examination, ensure a comprehensive evaluation of the complete clinical response. This assessment is essential for identifying patients who can safely avoid surgery and pursue non-operative management, highlighting the importance of endoscopic expertise in this process. In this slide, we can see the endoscopic view of the same patients at baseline, 10 weeks after chemotherapy, 16 weeks after chemotherapy, and 25 weeks after chemotherapy, where we see the changes through the weeks, and also at week 25, we see a complete clinical response. So here is the overview of the watch and wait surveillance protocol based on the International Watch and Wait Database guidelines, ensures meticulous follow-up after a clinical complete response. In the first 2 years, when regrowth risk is the highest, patients undergo the digital rectal examination every 3 months with regular endoscopy and pelvic MRI. CT scans every 6 months, monitor for distant metastasis. And after 2 years, assessments gradually reduced to annual intervals by year 5, ensuring early detection and timely intervention. Here we can see the NCCN latest guidelines for rectal cancer treatment, incorporating the non-operative management of rectal cancer. The watch and wait approach is, as I said, endorsed by the NCCN guidelines for patients achieving a complete or near complete clinical response after neoadjuvant therapy. It emphasizes organ preservation, quality of life, and requires precise evaluation and structured follow-up for safety, of course. Now we are going to a journey to the TNT trials. As you can see here from the 2016 Polish 2 trial, the Rapido trial, the Prodigy, the Stellar, the Dostarlimab trial, the OPRA trial, and 2023 and beyond, like the Beyond trial that we are still waiting for the results. So the Polish trial compared the short course radiotherapy with consolidation chemoradiotherapy to long course chemoradiation in advanced rectal cancer. The short course arm involved 25 gray and 5 fractions, followed by 3 cycles of FOLFOX4 before surgery, while the chemoradiotherapy arm included 50.4 gray with concurrent 5-FU leucovorin and oxaliplatin. Although the trial was negative for its primary endpoint, the residual resection rate 77 versus 71%, it showed significant benefits for 3 years overall survival in the short course arm. Additionally, this arm had lower toxicity and a higher, so not significant pathological complete response rate, 16 compared to 12. These findings support the potential of short course chemoradiation as a viable alternative, particularly for highly advanced cases. Then came the Rapido trial. The Rapido trial was a landmark phase 3 study designed to address the high risk of distant metastasis in rectal cancer. It compared short course radiotherapy followed by total neoadjuvant therapy to standard long course chemoradiation. Patients in the experimental arm received the 25 gray in 5 fractions over 1 week, followed by 18 weeks of CAPOX or FOLFOX chemotherapy, and then surgery. The standard arm included 50 to 50.4 gray of long course chemotherapy with optional chemotherapy followed by surgery. The trial enrolled high-risk patients with factors such as T4 and 2 diseases, positive mesorectal fascia, or lateral node involvement. The primary endpoint, 3-year disease-related failure, was significantly improved in the experimental arm at 23.7% compared to the 30.4% in the standard arm. Pathological complete responses was also significantly higher in the TNT arm at 28.4 versus 14.3 in the long-course chemotherapy arm, highlighting the enhanced tumor eradication with TNT. The Prodigy 23 trial evaluated the integration of Folfirinox-based chemotherapy into total neoadjuvant therapy approach for rectal cancer. Patients were randomized in 2 groups. One received conventional chemotherapy, total mesorectal excision, and adjuvant chemotherapy, and the other receiving upfront Folfirinox followed by radiotherapy, total mesorectal excision, and the short adjuvant therapy. This design aimed to address micrometastasis early and improve systemic control. The trial included patients with locally advanced rectal cancer, T3 or T4 tumors, no distant metastasis, and tumors located within 10 centimeters of the anal verge. The results were significant. Pathological complete responses rates were 28.3 in the TNT arm compared to 12.6 in the chemoradiotherapy arm, demonstrating better tumor regression and nodal downstaging. Furthermore, the 3-year disease-free survival was significantly improved with 75.7% in the TNT group versus 68.5 in the chemoradiotherapy group, and the hazard ratio of 0.69. These findings underscores the effectiveness of TNT with this approach in reducing the distant metastasis, enhancing treatment outcomes. So here we have the comparison of the local regional failure in Rapido versus Prodigy 23. The Prodigy 23 trial demonstrated lower local regional failure rates, 4.8% compared to Rapido 8.7%, despite similar pathological complete response rates in the experimental arms, 27.5 versus 28.4. This difference is primarily due to the radiotherapy protocol. So Rapido, short course radiotherapy, 25 gray over 1 week, followed by chemotherapy. Then Prodigy, long course chemoradiotherapy, 50.4 gray over 5 weeks with concurrent capecitabine. The prolonged and targeted approach in Prodigy 23 likely provided better pelvic control by addressing microscopic residual disease. This highlights the importance of long-course chemoradiotherapy for reducing local regional failure, especially in low rectal cancer, where achieving organ preservation and local control are the key. So let's move now to the next trial. It's the CAO-ARO-AEO12 trial. This was a multi-center randomized phase 2 trial conducted across 18 centers in Germany. Patients with locally advanced rectal adenocarcinoma, clinically stage T3 and 4 or node positive were included. They were randomized into 2 groups. Group A received induction chemotherapy, 3 cycles of FOLFOX, followed by chemoradiotherapy with fluorouracil, oxaliplatin, and then total mesorectal excision. Group B received chemoradiotherapy first, followed by consolidation chemotherapy, 3 cycles of FOLFOX, and total mesorectal excision. Key interventions included intensity modulated radiotherapy, 50.4 gray in 28 fractions, concurrent chemotherapy, and the mandatory TMA surgery scheduled 123 days after starting treatment. Non-operative management for clinical complete response was not part of the protocol, but occurred in 10 patients who refused surgery. The pathological response in this trial highlighted the significant impact of treatment sequencing. In the consolidation chemotherapy group, chemoradiotherapy followed by consolidation chemotherapy Pathological complete response was achieved in 25% of the patients compared to 70% in the induction chemotherapy group. This indicates that delivering chemotherapy after chemoradiotherapy not only maximizes local control but also enhances the overall tumor response. The higher pathological complete response rate in the consolidation group suggests that prolonged systemic exposure to chemotherapy along with the local tumor killing effects of radiation creates a synergistic effect, allowing more complete eradication of tumor cells. Pathological complete response is a critical endpoint in rectal cancer management as it correlates with improved survival outcomes and supports the possibility of non-operative management strategies such as watch and wait for selected patients, of course. The disease-free survival, both groups achieved comparable 3-year disease-free rates of 73% with no significant difference observed. Local regional recurrence failure rate were low at 6% for group A and 5% for group B with no significant differences. These findings underline the strong local control achieved with TNT. Distant metastasis in the group B showed a slightly lower rate of distance metastasis, 16% compared to group A 18%, but this difference was not statistically significant. The overall survival, both groups demonstrated high overall survival rates at 3 years, 92% for group A and 91% for group B with no significant difference. So this trial highlights that both TNT approaches achieve strong oncologic outcomes, but the consolidation-first strategy may be particularly effective in maximizing response and enabling watch and wait strategies for patients aiming to preserve their rectal and quality of life. So the next trial is the OPRA trial, a very important one in the watch and wait approach in organ preservation. It was designed to explore the effectiveness of 2 distinct total neoadjuvant therapy sequences in patients with stage 2-3 rectal adenocarcinomas. The trial compared induction chemotherapy followed by chemoradiotherapy, chemoradiotherapy followed by consolidation chemotherapy. Patients with tumors located within 12 centimeters of the annular verge were included, provided they had no distant metastasis and were candidates for TNT and surgical resection. A total of 324 patients were randomized equally between 2 arms. The TNT sequence were evaluated for their impact of disease-free survival and organ preservation. Post-treatment, patients were restaged using digital rectal examination, endoscopy, and MRI, depending on the response. Patients with incomplete response underwent total mesorectal excision. Patients achieving clinical complete response were offered a watch and wait approach. This rigorous design also incorporated a structured surveillance program for watch and wait patients, ensuring close follow-up and early detection of tumor regrowth. So we see here the OPRA trial 3-tier clinical response assessment scheme. This slide illustrates the OPRA trial's 3-tier clinical response assessment, which is central to its approach to treatment. After completing the TNT and waiting 8+ means 4 weeks for restaging, patients undergo a comprehensive evaluation using digital rectal examination, endoscopy, and MRI. The response is categorized into 3 tiers. Complete clinical response, patients with no visible tumor or residual disease on endoscopy, a flat white scar, and no residual tumor signal MRI are considered to have achieved complete clinical response. These patients proceed with the watch and wait approach, avoiding surgery. Near complete clinical response, patients with minimal residual abnormalities such as erythema or minimal thickening are also carefully evaluated with the option for close surveillance or surgical intervention based on risk assessment. Incomplete clinical response, patients showing significant residual tumor on endoscopy or MRI are directed toward total mesorectal excision, ensuring comprehensive tumor removal. The pathological response of the OPRA trial or the clinical complete response trial highlighted significant differences in outcomes between the 2 TNT regimens. Clinical complete response rates were higher in the chemoradiotherapy long course followed by consolidation chemotherapy arm 53% compared to the induction chemotherapy followed by long course chemotherapy arm 51%. Tumor regrowth rates during watch and wait in the chemoradiotherapy followed by consolidation chemotherapy were 27%, and the induction chemotherapy followed by chemoradiotherapy were 40%. These results underscore the advantage of chemoradiotherapy followed by consolidation chemotherapy in achieving better tumor control and enhancing organ preservation rates. Regrowth was significantly higher in the induction chemotherapy followed by chemoradiotherapy group compared to the chemoradiotherapy followed by consolidation chemotherapy group. This highlights that the chemoradiotherapy followed by consolidation chemoradiotherapy achieves better local control with fewer regrowth events, particularly within the first 2 years, which are the most critical for surveillance. Also, the distance-free survival for patients in the induction chemotherapy followed by chemotherapy group results indicate no significant difference between those two who had immediate TMA staging and those who required TMA after regrowth, with both groups showing comparable outcomes over the 6-year follow-up period. So Panel B displays distance-free survival for patients in the chemoradiotherapy followed by consolidation chemotherapy group. Similarly, the data reveal no significant survival difference between the immediate TMA and regrowth TMA groups. This finding highlights that performance salvage TMA after tumor regrowth offers equivalent disease-free survival to immediate TMA in patients with an incomplete response. This reinforces the safety of the watch and wait approach for organ preservation, provided there is close monitoring and timely interventions for the regrowth. We have also this year's the OPRA trial update. The OPRA update highlights critical findings for total neoadjuvant therapy in rectal cancer. Tumor regrowth, panel A, as we can see here, regrowth primarily occurs in the first 2 years with chemoradiotherapy followed the consolidation chemotherapy showing significantly lower rates than induction chemotherapy followed by chemoradiotherapy. The TMA-free survival, chemoradiotherapy followed by consolidation chemotherapy offers superior long-term organ preservation, 54% versus 39%. We are now looking at the 2024 meta-analysis published in Journal of American Medical Association Oncology, provided robust evidence supporting different total neoadjuvant therapy approaches in rectal cancer management, with the primary focus on pathological complete response, or PCR, as the main outcome. Among the evaluated strategies, long-course chemoradiotherapy followed by consolidation chemotherapy emerged as the most effective regimen for achieving pathological complete response, with a relative risk of 1.96 and the number needed to treat to just 7.5. This approach also demonstrated the best local lesional control, an essential factor for organ preservation. Short course radiotherapy with consolidation showed moderate effectiveness, while induction chemotherapy followed by long course chemotherapy beneficial was less impactful. These findings highlight the importance of sequencing with consolidation chemotherapy after chemoradiotherapy long course, offering a synergistic advantage in tumor response and organ preservation. So the highlight of this meta-analysis is the pivotal role of long-course chemoradiotherapy followed by consolidation chemotherapy as the preferred regimen, delivering strong evidence to support strategies like watch and wait. This approach shows the highest to achieve a clinical complete response and a pathological complete response with the intent of organ preservation, particularly in cases of low rectal cancer where surgery will result in a permanent stoma or is contraindicated due to factors such as significant comorbidities, advanced age, or patient preferences. It underscores the balance between oncologic safety and improved quality of life through tailored management and rigorous follow-up protocols. We will also mention the Dostarlimab trial in mismatch repair deficient rectal cancer, so-called the game changer in organ preservation. In 2022, study by Cercek brings groundbreaking results for patients with mismatch repair deficient rectal cancer by administering Dostarlimab and anti-PD-1 monoclonal antibody every 3 weeks for 6 months. The trial achieved a 100% clinical complete response with no evidence of tumor remaining on imaging, endoscopy, or biopsy. Importantly, none of the patients experienced a recurrence during a follow-up period ranging from 6 to 25 months. So this was like a study, paradigm shift study in rectal cancer treatment, eliminating the need for surgery or chemotherapy and avoiding the associated morbidity. The trial also reported no severe adverse events, demonstrating both efficiency and safety. This study directly connects to the watch and wait approach. By achieving complete clinical response with immunotherapy, patients can preserve their rectum, aligning perfectly with the principles of organ preservation and rectal cancer management. Further studies needed to confirm long-term durability and broader applicability of these findings, since only 2 patients were in this trial. We will also mention the OPRA trial. So the OPRA trial, published in the Lancet Gastroenterology and Hepatology, provided groundbreaking insights into organ preservation for early stage rectal cancer, conducted across 70 cancer centers. This multi-center phase 3 trial enrolled operable patients with low to mid rectal adenocarcinoma, focusing on tumors smaller than 5 centimeters with limited nodal involvement. All participants received neoadjuvant chemoradiotherapy, consists of 45 gray of external beam radiotherapy over 5 weeks, combined with oral capecitabine. Patients were then randomized to one of the 2 arms, an additional external beam radiotherapy boost or contact X-ray brachytherapy boost, also known as the papillon therapy. The contact X-ray brachytherapy boost approach uniquely delivers high-dose radiation directly to the tumor site, reducing collateral damage to surrounding tissue. The study demonstrated a significant advantage for the contact X-ray boost arm, achieving a 3-year organ preservation rate of 81% compared to 59% in the external beam radiotherapy boost arm. For patients with smaller tumors, the benefit was even more pronounced. Organ preservation was 97% in the contact X-ray brachytherapy arm compared to 63% in the external beam radiotherapy boost arm. Importantly, local regrowth rates were comparable between 2 groups, and salvage surgery remained a reliable option, both ensuring oncologic safety. Also this year, recently, there was the update of the OPRA trial that was published. The 5-year results of the OPRA trial confirmed the long-term benefits of contact X-ray brachytherapy in rectal cancer management. Organ preservation rates were significantly higher in the contact X-ray boost group, 79% compared to 56% in the external beam radiotherapy boost group, with exceptional outcomes for tumor under 3 centimeters, 93% versus 54%. Related toxicity, primarily mild rectal bleeding, resolved after 3 years, and bowel function remained intact. These findings underscore the sustained efficiency and safety of contact X-ray boost, particularly for smaller early-stage tumors, emphasizing its role in organ-preserving strategies. So, why consider papillon therapy for low rectal cancer, early low rectal cancer? TME is the gold standard for upper and middle rectal cancer. But abdominoperineal resection is often required for low rectal cancer, resulting in permanent stoma. For early stage rectal cancer, these surgical approaches can represent overtreatment with significant impacts of quality of life, of course. Not all rectal cancer require the same standard of care. For early, low rectal cancers, alternative approaches like papillon-therapy offer organ preservation while maintaining oncology safety. The role of papillon-therapy, the contact X-ray boost, targets early stage tumors with a high dose radiation boost, minimizes overtreatment by avoiding unnecessary surgery, and preserves organ functions and quality of life, making it a patient-centered approach. So what's next? One exciting trial we await results from is this phase 2 study comparing the efficiency of N-folfirinox against standard regimens like N-folfir6 and Capex, following long-course chemoradiation in patients with stage 2 or 3 rectal cancer. This trial's primary goal is to assess whether N-folfirinox can lead to higher rates of clinical complete responses, a critical factor in enabling organ preservation and watch and wait strategies. Secondary endpoints, including organ preservation time, disease-free survival, and overall survival, will further clarify the optimal approach for locally advanced rectal cancer. A unique exploratory objective also examines circulating tumor DNA kinetics, aiming to integrate molecular monitoring into treatment and surveillance. This trial represents a significant step forward in advancing non-operative management strategies, particularly for patients where surgery might lead to permanent stomas or those prioritizing organ preservation. But we must wait until 2025 for the results. So next, we are talking about the International Watch and Wait database. It was established in 2014 as a global registry aimed at collecting and analyzing data on patients with rectal cancer managed with the watch and wait approach. This strategy is employed in patients who achieve a clinical complete response after neoadjuvant therapy, allowing them to avoid surgery and preserve organ function. This is a collaborative effort led by key experts under European registration of cancer care with significant support from the Champalimaud Foundation. Data has been collected from 60 participating institutions across 15 countries, making the largest international registry for organ preservation strategies in rectal cancer. We have here the 5-year outcomes of the International Watch and Wait Database Registry data. We summarize key outcomes of the watch and wait approach, comparing local regrowth and distant metastasis-free survival with overall and disease-specific survival on the right. Starting with local tumor regrowth, on panel A left, approximately 25% of patients experience regrowth within 5 years, with most cases occurring in the first 2 years. This highlights the importance of close monitoring, particularly early on when the risk of recurrence is highest. For distant metastasis-free survival, panel B on the left, over 80% of patients remain metastasis-free at 5 years. This demonstrates the strong systemic disease control achieved with this approach when combined with appropriate neoadjuvant therapy and surveillance. Shifting to the right side, we see the survival outcomes. Overall survival on the panel A exceeded 85% at 5 years, reflecting the non-compromising nature of watch and wait on long-term survival. Finally, disease-specific survival, panel B right, remained even higher, above 90%, confirming that mortality directly related to rectal cancer was rare under this protocol. Together, these findings reinforce the watch and wait as a safe and effective strategy for organ preservation, provided that patients are carefully selected and undergo rigorous follow-up. Watch and wait at our clinic. Our clinic has been implementing the watch and wait strategy since 2017, with the first patient enrolled that year and the most recent in 2024. As part of the International Watch and Wait database, we are since 2023, we contributed to global efforts in advancing organ preservation strategies. All our patients under watch and wait were candidates for abdominoperineal resection surgery that would have resulted in a permanent stoma. By opting for this approach, we successfully preserved organ functions and improved their quality of life. Currently, we have 7 patients under surveillance, and I am proud to share that no regrowth has been observed to date. This demonstrates the effectiveness of our rigorous follow-up protocol, which includes MRI, endoscopy, and CT scans. Our clinic's commitment to organ preservation represents a significant step forward for rectal cancer management in Bosnia and Herzegovina, aligning with global standards and offering patients a chance for better outcomes without compromising oncological safety. So can we predict the complete clinical response and the pathological complete response before neoadjuvant therapy? Before starting, yes, the therapy. Recent studies highlight several promising markers. So I have listed here some relevant studies that investigated predicted markers before the start of neoadjuvant therapy. One of them investigated gene expression profiles, serum proteomic markers like HEP2, GELs, circulating tumor DNA, MRI-based radiomics, machine learning models, and so on. These advancements underscore the potential for integrating biomarkers and predictive models into treatment planning. This could allow for more personalized, targeted approaches, improving outcomes and reducing unnecessary interventions. So here are the key take-home messages that you can read. So the patient-centered care. Modern rectal cancer management emphasizes balancing oncological safety with quality of life through organ preserving strategies. Watch and wait evidence-based approach offers selected patients the chance to avoid surgery, ensuring close surveillance and oncologic safety while preserving function. The total neoadjuvant therapy has transformed the treatment landscape by improving systemic control, increasing the complete clinical response rates, and supporting organ preservation. Landmark trials like Polish trial, OPRA, Rapido, Prodigy, and OPRA have provided critical insight into optimizing outcomes for rectal cancer patients. Long-course chemoradiotherapy followed by consolidation chemotherapy demonstrates superior results for achieving complete clinical response and pathological complete response, making it the preferred approach for organ preservation in rectal cancer. Ongoing research into biomarkers and imaging aims to predict treatment responses before therapy, paving the way for truly personalized care. The OPRA trial demonstrated the long-term success of contact X-ray brachytherapy in enhancing organ preservation without compromising safety. And incorporating predictive tools, innovative therapies, and collaborative research will further refine strategies for personalized and patient-focused rectal cancer management. So thank you for your patience. This is my clinic, the Oncology Clinic in the Clinical Center of the University of Sarajevo. This is our team with our head of the clinic, Professor Amil Družić. And if you grew up playing this, you probably need to schedule a colonoscopy. Thank you for your attention. You can scan this QR code and follow me on social media. Bye-bye.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.